Hello, my name is Enrique Grande. I'm the head of the Medical Oncology Department at the MD Anderson Cancer Center in Madrid, and at the same time, I'm leading the clinical research of the foundation of the hospital. Bladder cancer is one of the most common tumors that we have worldwide. This is in between the 9th and 11th most frequent tumor in the world. It is depending on the region, and this is very associated with age and the smoking habit. So because we are living longer and because unfortunately we are smoking more and more, well, unfortunately the trends of incidence, new cases of bladder cancer are increasing in the recent years. This is not something bad because most of these cases are diagnosed in early stages. We estimate that around 70% of the patients with bladder cancer are diagnosed when the disease is still placed in the bladder. So patients can be operated and then can be cured about this devastating disease in case of metastases are happening. Patients with urothelial carcinoma, patients with bladder cancer, when they are becoming metastatic, we have a new reference standard of care to treat them systemically. Traditionally, we were offering for cisplatin or carboplatin-based chemotherapy. This upfront treatment didn't change. What it has changed, and now we have this new reference standard of care, is that after 4 to 6 cycles of this platinum-based chemotherapy, we have the opportunity to give our patients the treatment with avelumab as a maintenance strategy. In the past, we were stopping the chemotherapy and we were just waiting for the tumor to progress again. Now, with this use of immunotherapy as a maintenance strategy, we get an improvement in the overall survival. And because of the good tolerability of immunotherapy, we get that these patients are living better in time. So this is a very good advance. However, we have a lot of challenges so far. And the main challenge is coming because we don't have reliable biomarkers to predict the efficacy, not only for chemotherapy, but also for immunotherapy. This is the most important challenge that we will need to face shortly in this field. Those patients with metastatic urothelial carcinoma are changing in the armamentarium, in the drugs, in the algorithms that we have to treat when patients have developed metastases. But today, we know that these new options, these new drugs, are moving to early stages of the disease, stages in which the tumor is still in place in the bladder. So there is a lot of research coming through the field in which we can avoid the use of cystectomy, the need of cystectomy, the removal of the bladder. That would dramatically change the quality of life of our patients if we don't have the need to operate the bladder, if we can keep the bladder in place. That what it is changing in daily practice? Well, first, the multidisciplinary approach. Definitely, urologists, oncologists, pathologists, radiologists will need to work together to try to ensure that all those patients with primary tumors located in the bladder, well, may have the opportunity to preserve the bladder and not need to do the cystectomy. This is the change that is coming shortly in this field. In addition to that, and don't forget that the majority of the patients are diagnosed in early stages, where the tumor, the bladder cancer, is not yet infiltrating the muscle. This is what we call the non-muscle invasive stages. We have new devices that are settled, are placed inside the bladder, and they are releasing slowly some medications, including not only the classical BCG, but also immunotherapy and chemotherapy, contributing to control the local dissemination of this non-muscle invasive bladder cancer. So hopefully in the future, cystectomy will not be needed anymore because of the activity of the treatments that we have for this particular subgroup of patients. For patients with metastatic urothelial carcinoma, we have a new horizon that is in front of ours, in the sense that new drugs will be coming and will be added to our armamentarium to treat these patients, novel antibody drug conjugates. And this kind of antibody are like a Trojan horses, in the sense that these antibodies, in one hand, they are binding to the tumor cell, and in the other hand, they are bringing chemotherapy with them. So in one hand, they bind to the tumor cells, they get the chemotherapy inside the tumor cells. So this is like magic bullets that we can use today in the clinic, and shortly we will be available in countries like India, like enfortumab vedotin or sacituzumab govitecan, the new drugs that we have in this field. In addition on that, precision medicine is coming to the field of urothelial carcinoma, and we know that patients with molecular alterations affecting to the gene encoding for the fibroblast growth factor receptor are important to take into consideration because of the new development of the FGFR inhibitors targeting these patients with mutations or fusions affecting to the FGFR3 gene. On top of that, we have the combinations of novel antibody drug conjugates plus immunotherapy, FGFR inhibitors plus immunotherapy, and other new drugs that are coming into this field shortly. Hopefully, in the future, we will have not only one or two lines of systemic treatment to offer, but we will have at least 3, 4, 5 different lines to offer, contributing to an improvement in the overall survival and an improvement in the quality of life of our patients.